Good to see you.
Likewise. I'm always so surprised when it
Yes.
works.
How's your family? How's your day going?
Good. How are you? How is everything?
Good.
Good.
Everybody's good. I love my team. They're here.
Good.
It's been really nice.
Yeah.
Yeah, working hard and
Amazing. Well, thank you for all that you do for the fertility community. And I guess before we even jump into having this amazing conversation about secondary infertility, do you want to take a second to reintroduce yourself to the HTICFA community?
sure. I'm Dr. Carolyn Alexander. I am part of Southern California Reproductive Center, and it's an honor and a privilege to take care of all our lovely patients who are thinking about fertility and on their journey. I trained at Johns Hopkins Hospital and worked for Cedars-Sinai for 8 years, and I've been here for 11 years at SCRC. And I work closely with a wonderful group of embryologists. We meet often to go over how to improve egg survival of the egg thaw. What can we do to get embryos to have better implantation? So we're always trying to stay on the cutting edge and help patients.
That's wonderful. And thank you. Thank you for all that you're doing for your patients and to help with the furthering of growth within this field. It's such an important and ever evolving field. And it's incredible even to see in the 10 years that I've been touched, or actually more at this point, 14 years, how much science continues to evolve on a yearly basis. It really is so incredible.
And
So thank you.
I love how you bring awareness. It's so important. I have your cards over here, so patients sometimes really need a lot more support,
Yeah,
and they
thank you.
feel really supported with you and your efforts. It goes. I feel like it makes a big difference. So
I appreciate you for saying that. We hope so. That definitely is the goal. The goal is that no one should have to ever face a fertility journey alone, and everyone should have community to lean on, and their family and friends should have resources to better understand what they're going through, so that they can also show up for them.
exactly. Yeah.
So we have a really interesting topic today. We're going to be speaking a little bit about secondary infertility. I know that it's been this week the conversation we've been having on our socials in terms of education and connection around it. And I think it's sometimes a space within the fertility community that could be forgotten. Primary infertility seems so much more obvious to many people, while secondary infertility, you can speak to its prevalence and the difference between the two. But I think that it is a very valid pain that so many individuals experience, of being both dually grateful for what they have already, while also so desperately wanting what they don't yet have, which are two very valid experiences to hold at the same time, yet so hard to juggle that those two very opposing experiences emotionally. And I think that for the community at large, looking in on someone who is in struggle like that, I think a lot of times, for those who've never experienced it, being comments like, well, at least you have one, or at least you have two, like, be grateful for what you have, which just adds a lot of salt to the wound of not being able to have what you so desperately still want.
Yes, I think it's interesting because a lot of patients will say, it was so easy with the first. I got pregnant on, the first time I thought about it to try, and then it's been a year, we're trying again. Sometimes when we look at the history, their periods may have changed, or the flow could be heavier or lighter, and sometimes that's estrogen. If estrogen's low from stress or nutrition changes, or sometimes hypothalamic amenorrhea and things like that, they may have an issue where the lining isn't thickening like it used to. And sometimes having a little one at home adds sleep disturbances. And when your sleep disturbances are disrupted, then your pituitary also can be impacted. Occasionally, the LH surge doesn't occur as robustly. So if your body isn't signaling ovulation in a strong manner, it can be like a hill instead of a peak and a trough. So people will say their home ovulation kit doesn't seem like it's working as well as in the past. It was like clockwork, and then now. So sometimes there's little small nuances that we can do. Since COVID hit and since the fires in Los Angeles, we do sometimes see sperm quality changing.
Interesting.
So we always think of us, our side of it, as the egg and the ovulation and the uterine lining, but sometimes male factor can pop up. Sometimes some blood pressure medications. I had a guy just change his blood pressure medications, and his semen analysis improved profoundly, and that will help a lot. You know, it's not a hard fix. Sometimes the fallopian tubes, because they were open, we always sort of assume they are, but the HSG is a helpful tool because it kind of flushes the system. It's uncomfortable. I've had it done. It's just, you know, it's a test that could be valuable to kind of reopen or reflush the tubes. And so also getting your annual physical exam, because sometimes we'll catch autoimmune things or psoriasis and eczema and little things that cause inflammation, and that can make an embryo harder to attach in the natural body, like nature. And then I think the harder conversations are, you know, a younger patient had an easy first pregnancy, and then lo and behold, their ovarian reserve changed to be what's called diminished ovarian reserve, where the AMH level changed and it went down, and that's your egg supply level, or the FSH on your third day of your period with estradiol being checked can change to show a sign of diminished ovarian reserve. And I think that's more of a red flag where time's not on our side, even at any age. And you might need to really jump onto treatment plans and be proactive, because those levels are used to guide us on how to treat, you know, create an optimal treatment plan.
Right. Yeah. And I know that there's a lot of conversation around this. We're speaking right now about individuals who were able to have a pregnancy or multiple pregnancies and then are diagnosed with infertility. Is there a difference in how one treats a patient who had primary infertility and now continues on to have had a first child or multiple children and wants to continue to pursue fertility treatments to continue to grow their family? Do they fall under this category of secondary infertility?
That's a really interesting question. It's important to think it through. I think in any case, we always still kind of lean back on the basics of ovarian reserve testing, semen analysis, reevaluate maybe the uterine cavity or fallopian tubes, make sure there's no other metabolic problems or hormonal issues like prolactin. If you're still night nursing, sometimes the prolactin can be elevated and it can hinder ovulation. So people will say, I'm getting my period every month, but I think I'm ovulating. I should be ovulating. But then they'll say, oh yeah, but I'm still doing night nursing to my little one. Yeah. And that might be, it may impact prolactin. And when prolactin's high, it's a little harder for the egg to kind of journey in the process. So I think of it mechanistically, like it's like, might be a little harder. Sometimes the uterine lining's thinner when the prolactin's also really high too.
Interesting.
And there are prolactin receptors on the adrenal gland, and it can produce DHEAS at a higher level, which also can impact the environment too.
And sorry, so for those of us who need more layman's terms, can you explain that?
Oh, yes, sure.
Yes.
So
thank you.
a hormone from your pituitary gland is also called prolactin. And it's one of the tests we do in our fertility evaluation. We think of FSH, which is your egg quality level, estradiol, as well as prolactin, thyroid. If you have signs of polycystic ovary syndrome there's a panel called an androgen panel or a male hormone panel. And if you have extremely painful periods or pain with intercourse or pain at the time of ovulation, we put on our radar to check for endometriosis too, as well. So these are little tests that we do to try to determine what treatment plan to come up with.
So if someone is struggling and they've had children before and now they're struggling to grow their family, what advice would you give them in terms of timeline to come in to see an REI? Because I think that often in one's mind, but I've been able to get pregnant on my own before, why do I need to go get evaluated? So what advice would you give?
Yeah. If you're under age 35, you may have a bit more time than when we're older than over 35, because the blessing of a genetically good egg starts to go down as we get over age 35. Right. So after age 35, we would say 6 months, as long as your menstrual cycles are regular. If the menstrual cycles are different, it's good to talk to your OBGYN. When we're younger than 35, realistically, it can be a year, but even at 6 months, it could be important to at least start the discussion to evaluate.
Amazing. What other advice would you give individuals as they are going through their secondary infertility journey once a diagnosis has been made, in terms of communication with their doctor and through the journey?
Always keep hope, because you've conceived before, so we know the egg and sperm can combine, and that's always like a good sign that the system, really has the ability to be pregnant again. I think it's also important to open up communication with your partner, because I notice sometimes the, discussion between the couple may be interesting. So it may feel sensitive, but to discuss, have an open conversation. Definitely, if you have specific fears or questions, it's good to ask your doctor or friends or you guys, for support, because I think in my mind, if it's secondary infertility, it feels like there's a higher odds, but in general, I think it's good to open up the discussions.
Beautiful. So important. Open communication and knowing that you could turn to your doctor and to ask your concerns and questions is so important. I appreciate that. Is there any maybe a anecdote or story that you would want to share in terms of through your work and individuals that you've seen through this journey?
Yeah, I think, I'm a big believer. Every month there's a golden egg that we can ovulate. We just have to try to think of mindfulness, vitamins, if you like acupuncture or yoga, to try to lower our cortisol. It's good in our sleep pattern not to disrupt it with the computer or phone the hour prior to sleep, even though that's hard to do sometimes, but it's important. Toxins for our partners is important, and optimizing vitamin D levels in men has been shown to improve sperm quality and in general ideal body mass index, even though again that's also sensitive and hard to talk about sometimes with our partner. It does, you could say, work together on the journey to improve our health overall for the kids too as well. But that's it.
Amazing. Thank you so much. Thank you for sharing. Is there any last thought or advice that you would want to leave individuals on this journey with?
Sending good vibes and hoping everybody has a good, journey. And if you need anything, we're here for you here.
Thank you so much. And we'll be sure to tag you on this so that individuals can come and find you.
Thank you. Cheers. Take care. Good to see you.
Likewise. Thank you.
Bye.